We can dichotomize the sources of data into two broad categories. We have your primary data and you have your secondary data. When I say primary data, these are information obtained by the investigator himself or herself firsthand, and it is specifically aids the investigator in answering the different objectives or purposes that he or she has set for his or her particular study. For example, data gathered from surveys, interviews, if you conduct tests, let's say blood examination, all of these ancillary diagnostic procedures done on individual patients and or subjects to determine whether or not a respondent would fulfill or meet the criteria for him or her to be diagnosed with a particular medical condition. These are all examples of what we refer to as your primary data. In this particular course, you have for this particular course in epidemiology and research methods, one, you will have the opportunity to gather firsthand data and or primary data in the form of what we call this exercise, the community diagnosis. Now, the last time, to my recollection, the last time we were able to successfully bring all our freshman students to our adopted communities was way back in April 2019. This was the last time that we were able to successfully mobilize our linkages. We coordinated with the Sangguniang Barangay ng Dolores of Taytay Rizal. We coordinated with the Sangguniang Bayan ng Taytay Rizal for us to bring 450 freshman students to our adopted community back then in Barangay Dolores, Taytay Rizal. It is such a logistical difficulty to transport and supervise 450 freshmen in the community. But this was a very it was an eye-opening experience for a lot of the freshmen because this was the first time that they had the opportunity to engage with community members, in particular the indigent members of the community. So they did home visits. They visited families in Taytay and they did a long survey. And from the data that they gathered, they were able to paint a picture of how good or how bad or how, for lack of a better term, or how lacking some of the services are in this particular area in Taytay Rizal. So then the pandemic happened. We were supposed to have this activity in April 2020. But of course, you do know from history that the COVID-19 pandemic happened. And so we weren't able to bring our freshmen to the community since 2020. I think this is once again the first time we are bringing all 600 freshmen to the community. It's really it's a bit nerve-wracking on our end because it could be a logistical nightmare to ensure the safety of our students in the community. But we are trying our best to maximize the learning experience of our freshmen for you to have information on how to gather data that will allow you to further understand the state of health of the community that you will be visiting. If I am not mistaken, for this particular semester, since we have partially moved out of Taytay Rizal, we will be bringing you to our new adopted community somewhere here in the urban poor areas of San Juan, most probably, but I'm not yet sure if this has been finalized. But to my recollection, we will be bringing you to West Crame. This is in San Juan. West Crame is one of the barangays in District 1 of San Juan City, if I am not mistaken. And we will bring you to this area, I think, by April of 2024. So again, the experience will be the same. It will allow you to perform home visits, do the interview, and gather data that will be considered primary source for you to come up with your community diagnosis report. The community diagnosis will further be discussed by one of our junior faculties in the next the next couple of weeks. But just to give you the heads up that within this semester, we will be bringing you once again, we will be bringing our students to our adopted community in West Crame, San Juan City here in the National Capital Region. Then you have your secondary data. Secondary data are those obtained by other researchers for purposes not necessarily the same as those of the investigators, and therefore are considered as previously existing information, which might just be helpful in your current investigation. Generally, this type of information has a large bearing with regard to the quality of facts obtained, since the investigator has no direct control over how the data were collected, the objectives behind the data collection, and the definitions used in classifying individuals into the myriad of categories of the variables being considered. Now, when do we use data, and what will be the experience of our medical trainees when it comes to secondary data? Our postgraduate interns currently rotate in the social hygiene clinic in Barangay Batis of San Juan City. Through the efforts of the UERM MMCI Community Extension and Social Action Unit, we have forged formal partnership with the Sangguniang Panglungsod ng San Juan. And in particular, we are coordinating with the San Juan City Health Office. The San Juan City Health Office identifies which particular barangays that our clinical clerks and or postgraduate interns will visit and render health services. Now, Barangay Batis happens to be the HIV/AIDS treatment hub of San Juan City. And so we do have a lot of uh, peer navigators, peer counselors who are trained in HIV counseling. This is where we cater to people living with HIV or the PLHIVs. This is where we give pre-exposure prophylaxis, post-exposure prophylaxis, as well as your antiretroviral therapy for people living with HIV in San Juan City. So every patient encounter at the social hygiene clinic are technically reported to the San Juan City Health Office, and the San Juan City Health Office consequently refers this to the CESU, or the City Epidemiological and Surveillance Unit, which is also mandated to report notifiable diseases to the Department of Health for purposes of data gathering to monitor mortality and morbidity and mortality related to HIV/AIDS. So, if you are interested, excuse me, if you are interested to conduct studies that are related to HIV/AIDS, you can actually tap our peers, our colleagues at the San Juan City Health Office, in particular at the Barangay Batis Social Hygiene Clinic, if you want to get data on the morbidity and the morbidity related to HIV/AIDS. For example, you are interested to know whether or not there are ongoing fungal, viral, opportunistic infections that are evident among those with immunocompromised, who are in an immunocompromised state, and the data that the social hygiene clinic can prove to be pivotal for your particular study, then this is an example of your secondary source of data. Now, I've mentioned that there are certain medical conditions that have to be reported diligently to the health authorities. Now, there are what we call your reports of occurrence of notifiable diseases. These are certain medical conditions that are required by law to be notified or reported immediately to health authorities upon the recommendation of our Department of Health. These reports of occurrence of notifiable diseases provide information regarding the morbidity status of the community. This is similar to what I have already mentioned when I was referring to the people, the social hygiene clinic at the Batis, Barangay Batis Social Hygiene Clinic. The reporting of these diseases is generally done on a weekly basis and is therefore required for purposes of surveillance and monitoring of important communicable and infectious diseases. Now, data on identifiable diseases are based on information submitted by health personnel of different grassroots institutions, including your rural health units, your city health offices, or your provincial health offices, and sometimes even your municipal health offices. Now, why do we do this? Why should we report? Because this is stipulated under Republic Act 3573, or the law on reporting of the notifiable diseases, which mandates the immediate accounting of any communicable disease of public health interest to the nearest health officer. Now, later on, I will talk about Republic Act 11332, which is supposedly another law passed in 2020 to augment the provisions of, or the stipulations of Republic Act 3573. Now, under Republic Act 3573, we have also created the what we call your Philippine Integrated Disease Surveillance and Response, or the PIDS-R. Now, under this, PIDS-R has identified several medical conditions that are of public health relevance. These are those that are considered epidemic prone, those that are targeted for eradication or elimination, and other diseases or conditions of public health importance. I would highly recommend that you also read on the updated 2020 implementing rules and regulations of Republic Act 11332, which is the newer version of this particular law that defines what we mean by public conditions of public health importance and what do we mean by those that are outbreak prone or epidemic prone. So again, to supplement your learning, I would recommend that you do further reading or supplemental reading on the said IRR, or the implementing rules and regulations, once again, of Republic Act 11332, which pertains to the newer uh, reporting or surveillance of these particular notifiable diseases. But interesting to note that some of these conditions are of tropical medicine importance as well. And we do see these conditions in the Philippines. In particular, note that we also have here some of those considered emerging and re-emerging infectious diseases. And I will also briefly touch on this in a short while. From a public health perspective, when we're talking of epidemiological investigation, we also have to differentiate those that are identified for possible eradication and those that are for elimination. So I'd like to make this interactive. By any chance, can anyone tell me what is the difference between eradication and elimination? Do we have volunteers from our freshies? Can anyone differentiate for me what is eradication and what is elimination? Any volunteers, please raise your hand and I will acknowledge you. Yes, Miss Marasigan, can you differentiate the two, please?
Good morning, Doc.
Good
Uh,
morning.
from
Can
what
you
I
turn on your
remember,
video camera? I want to see your face.
Doc, it's broken po, sorry.
It's okay. Sige. So how do you differentiate?
Eradication po, the disease is completely reduced na po worldwide, whereas elimination po, reduced lang siya to a specific region, if I remember correctly po.
Well, good try, but not quite the answer I'm looking for. Any other volunteers who would like to differentiate eradication from elimination? Thank you, Miss Marasigan. Can I hear from other people? Hanap tayo ng ano. Hanap tayo ng magandang display photo. Sige. So can I call on Miss Enriquez, Javian Elise, Javian,
Good
Miss
morning
Enriquez.
po.
Good morning.
I think elimination, parang ano po siya, kailangan pa po ng preventive measures po for the community. Meanwhile, eradication po, hindi na po necessary yun, Doc.
Okay, so if I were to combine your answer with the answer a while ago of Miss Marasigan, I think we hit the nail on the head. So when we're talking of elimination and eradication, both of them already have zero incidence. I hope you remember the definition of incidence rate. When we're talking of incidence, it is the number of new cases among the population at risk. So for both elimination and eradication, both have already achieved zero incidents. There are no new cases that are being reported with regard to a particular condition. However, there is a big difference in terms of how do we sustain and how do we maintain that zero incidence. For example, in the Philippines, we have already eliminated poliomyelitis way back in 2010. And for several years, it was part of the bragging rights of the Department of Health that we have achieved elimination of poliomyelitis. But for us to maintain that zero incidence, we were staunchly advocating for the regular vaccination of our children under the expanded program on immunization. And part of the vaccination program would include the giving of your poliomyelitis vaccine. However, sadly, because of the controversies that resulted in the Dengvaxia issues, people started to question the validity and the benefits of getting vaccinated. And so slowly we started to see people who were not being vaccinated, children who were not being vaccinated for poliomyelitis, and we started to get the re-emerging of this particular condition to the point that sometime during the pandemic, if you will recall, sometime from 2021 to 2022, amidst the COVID-19 pandemic, the Department of Health gave out an announcement that we are now seeing once again, poliomyelitis, the wild type of poliomyelitis in the Philippines. And so we lost that status of zero elimination. So again, pag elimination, there is zero incidence. However, we have to actively do a public health intervention to maintain or sustain that zero incidence. On the other hand, when we're talking of eradication, I think the best example for this will be your variola or your smallpox virus. The variola has been successfully eradicated from the face of the earth. Meaning to say, whether you are in Asia, in South America, in Africa, or where have you, there are no more incidents of variola or your smallpox. And do we vaccinate people for smallpox? No, we don't. There is no active intervention being done to maintain or to sustain that zero elimination or zero incidence rate. That is why it is considered eradicated already. Of course, you might hear conspiracy theories that both Russia and the US have the variola in their supposedly in their military laboratories that are being kept supposedly for bioterrorism acts or whatever. But again, these are just all conspiracy theories that we might not be able to really resolve or identify if they are factually true. But the issue with regard to the definition of elimination and eradication as as defined by the Centers for Disease Prevention and Control, these are some of the things that we have to also identify. So again, if you are seeing those conditions that are being targeted for elimination or eradication, we ought to report these to the health authorities as stipulated by our Philippine laws. Now, when it comes to notification of diseases, the quality of diagnosis can sometimes pose a limitation to this particular data source. Since facilities for doing laboratory tests are usually lacking, in particular in the geographically isolated and disadvantaged areas of the Philippine archipelago, you've heard of the GDAS. Sometimes the diagnosis of doctors are primarily based on clinical grounds, meaning to say there are no corroborating diagnostic tests or ancillary procedures that have been done to support or to clinch the definitive diagnosis of a particular medical condition. And I'll be more specific. When we're talking of tuberculosis, if you read the latest guidelines on how do we diagnose pulmonary tuberculosis, there is what we call your bacteriologically confirmed TB, meaning to say they were able to isolate the Mycobacterium tuberculosis in various diagnostic tests. It could be your sputum smear microscopy, it could be your polymerase chain reaction, your gene expert, or whatever tests that may be used, such as your lamp. Those are what we call are the ones that are grown in culture for this particular species of your Mycobacterium tuberculosis. However, there are those patients who are diagnosed by their attending doctors to have tuberculosis if they have the overt signs of, let's say, um, fever, unexplained fever, productive cough of at least 2 weeks, weight loss with multiple cervical lymphadenopathies o mga kulani, or let's say on X-ray, you already note reticulonodular densities in the chest X-ray, then you can come up with a clinical diagnosis, a clinical impression of pulmonary tuberculosis, even in the absentia of your diagnostic test. That is something that is acceptable. But there is this issue whether or not it's really confirmed or just a presumptive diagnosis. So this is something that could also limit the way we notify medical conditions. In rural areas, again, where doctors and healthcare providers are the ones who are at the forefront, especially once again in the GDAS, the geographically isolated and disadvantaged areas, sometimes you just do symptomatic diagnosis. The clustering of particular signs and symptoms would allow us to come up with certain medical conditions. For example, if you've heard of the World Health Organization's Integrated Management of Childhood Illnesses, or your IMCI or your IMC, your IMC was designed to particularly aid your community health workers, or sometimes your midwives, where there are no doctors in their region or in their locality. The IMCI or the MC allows the midwives to come up with impressions such as measles, probable measles, or possible pneumonia, or those with severe lower respiratory tract infection, even if they're not trained to do physical diagnosis, or they are not allowed to request for diagnostic tests. So this is something that is acceptable, but then again, it could affect or it could impact on the quality of the diagnosis. So I mentioned about Republic Act 11332. This is the mandatory reporting of notifiable diseases and health events of Public Health Concern Act of 2022. This came about with the beginning of with the advent with the occurrence of the COVID-19 pandemic. So I want you to read on this because I cannot teach you, I cannot explain all 90 pages of this Republic Act, but I want you to go over the implementing rules and regulations, the basic concepts related to epidemiology, in particular, those that are designed for disease control and disease response and disease surveillance. So there are three things that I want you to read on: disease control, disease response, and disease surveillance. When I say disease control, I am referring to the reduction of disease incidence, prevalence, morbidity, or mortality to a locally acceptable level as a result of deliberate efforts and continued intervention measures to maintain such reduction. Once again, I hope you know the difference between incidence rate and prevalence rate, because even in our laws, in our Philippine Republic Acts, these terms are properly used by the experts. Then we have the concept of disease response. Disease response will refer to the implementation of specific activities to control further spread of infection, the occurrence of outbreaks or epidemics, and to prevent the reoccurrence of these epidemics. So this will include proper verification, contact tracing. I hope you, from our experience with the COVID-19 pandemic, I hope you know what we mean by contact tracing, rapid risk assessment, case measures, treatment of patients, risk communication, conduct of prevention activities, including rehabilitation and reintegration into society. This will also include, but not limited to, movements and restrictions, partial or complete closure of schools and businesses, imposition of quarantine in specific geographic areas, and international or domestic travel restrictions, construction of facilities for quarantine, and the pre-positioning and distribution of personal protective equipment for health workers. So out of curiosity, can anyone differentiate for me quarantine and isolation? Anyone? What's the difference between isolation and quarantine? Can I call on, let's look for other people na, ano, are ba mag-volunteer? Sige, can I call on Mr. Diego Gabriel Gonzaga? Mr. Gonzaga, are you with us?
Hello po, Doc. Good morning po.
Hello. Can you turn on your video camera? What's the difference between isolation and quarantine? Mr. Gonzaga, are you with us?
Hello po, Doc.
Hello.
The difference between isolation and quarantine po is in isolation po, I guess there's no specific number of days that you isolate yourself from other people. And in quarantine, there are specific number of days po na you need to be isolated naman from other people po. Am I correct po ba, Doc?
Good attempt, but not quite the answer I'm looking for. For a while, I'm having difficulties. So, yes, Dr. Alcanzari, you want to say something? Dr. Alcanzari, you're raising your hand.
Yes, sorry.
Go ahead, you want to say something?
Sorry, sorry. Pabibo tuloy. Yung difference between yung isolation and quarantine is yung quarantine in the context of the pandemic, as somebody who was in the times and somebody who has experience with MERS, yung quarantine is a sort of preventive response. Parang you have a suspected person or suspected case ng disease under in to ensure that even if they don't have it, there's enough time that's passed for it to resolve at hindi kumalat din sa population. Whereas yung isolation is
You're a bit choppy, Dr. Edri. Did we lose Dr. Edri? I think wait, there's something in the chat box. Sige. So yeah. Go ahead. You were a bit choppy, Dr. Alcanzare. Can you repeat what you said? Isolation.
Whereas isolation, you already have a confirmed, not necessarily confirmed, but already manifesting symptoms of the disease in question. So the patient has what looks like the disease, and you're trying to prevent the patient from coming into contact with the rest of the population, so that other people will not be part of the contagion. So yun yung difference between quarantine and isolation. Thank you, Dr. Javier.
Okay, thank you for that, Dr. Alcanzare. So to summarize, actually there's also someone, Mr. Galicia also sent a private message to me in the chat box. Both are correct, no? So to make it simple, for quarantine, we are restricting the movement of those who have been exposed to a particular diseased individual, thinking that that particular exposed individual may also have the capacity to transmit this particular infection. That's why we restrict their movement, usually in a time period that would refer, or that would be more or less mirroring the incubation period for a particular medical condition. In contrast, when we're talking of isolation, we are referring to the restriction of movements of those who already have the overt clinical manifestations and or the confirmed, the diagnosed cases already. And we want to make sure that they are not transmitting it to other individuals. That's why we restrict their movements. So from a public health perspective, these are all examples of interventions that would pertain to disease response. Then we also have your disease surveillance, which refers to the ongoing systematic collection, analysis, interpretation, and dissemination of outcome-specific data for use in the planning, implementation, and evaluation of public health practice in terms of epidemics, emergencies, and disasters. A disease surveillance system will include the functional capacity for data analysis as well as the timely dissemination of these data to individuals who can undertake effective prevention and control activities. Now, important to this Republic Act 11332, nakakalito na kasi Universal Healthcare Act is 11223. Ito naman 11332. So anyway, so dito naman, we also in Republic Act 11332, we also have the concept of those that are identified as emerging and re-emerging infectious diseases. And from a public health perspective, this will also include some of your neglected tropical diseases. So when we say what are the criteria that our law utilizes to operationally define emerging and re-emerging infectious diseases, these are the operational definitions. Those infectious diseases that have never occurred in humans before, have occurred previously but affected only small numbers of people in isolated areas, have occurred throughout human history but have only recently been recognized as a distant disease due to an infectious agent, are caused by previously undetected or unknown infectious agents, are due to mutants or resistant strains of a causative organism, or once were major health problems. However, they have declined dramatically, but are slowly, once again, becoming health problems for a significant proportion of the population. Again, these are just some of the operational definitions of your emerging and re-emerging infectious diseases, no? With regard to this, na yung mga lumalabas na mga re-emerging, na for example, yung mga ano ba, yung mga naririnig nyo na, for example, your technically na yung mga kapag dati yung poliomyelitis, dating na-eliminate, tapos biglang ngayon nagkakaroon ng bagong incidents, or we're seeing more and more people getting wild types of your poliomyelitis, then that can be considered a re-emerging infectious disease. So again, just to give you an operational definition of what the Department of Health or the health experts would consider as part of your emerging and re-emerging infectious diseases. Now, in the IRR of Republic Act 11332, they also have identified, let's say, diseases that are for disease survey, the medical conditions or infections that are for disease surveillance that are spread, let's say, via droplets, via vectors. So again, I want you to read on the IRR of Republic Act 11332, because I will not be able to explain in further detail all stipulations of that particular IRR. So please do supplemental reading on this, because we might ask this also in your upcoming exams. Again, in the IRR, we also have what we call your category 1 emerging, re-emerging infections. These are medical conditions that have to be promptly be alert. We have to promptly alert the health experts. These are some of the conditions that have been identified as your category 1 medical conditions that would warrant prompt referral to the DOH. In contrast, there are medical conditions that could be reported on a weekly basis, and they are considered category 2. So for academic purposes, I'm just putting them here for your perusal and for your further supplemental reading. And I want you to be more familiar with these conditions, at least get an idea of what these conditions are in the event that you haven't heard of these. For example, when we're talking of red tide, that would include the um, contamination of toxins coming from dinoflagellates or from diatoms or from algal blooms. It could result in your paralytic shellfish poisoning. So these are some of the things that you need to know from a public health perspective that would be of clinical relevance to our health sectors. So we've discussed the notifiable diseases. We've also, the second part of my objectives is how do we also use data that we gather from civil registries of vital events. Vital events would often relate to the birth or to the death of an individual. Civil registration is the continuous, permanent, compulsory recording of the occurrence and characteristics of vital events as defined and provided through decree or regulation in accordance with the legal requirements of each country. It is done primarily for their value as important records or legal documents, and secondarily for their usefulness as sources of morbidity, mortality statistics. Now, the first of these vital events is how do we accomplish the certificate of death? Again, the certificate of death is a permanent legal record which contains an individual's death information. It provides important information and data on the circumstances surrounding the death, and the information from the death certificate has various uses. It can be used for settlement of claims, inheritance, insurance benefits, as well as proof of death. And the certificate of death is likewise provided to the family for purposes of requirement for burial arrangements. Now, I know this might be like an information deluge for some of you, but by the time you become clinical clerks and or postgraduate interns and or resident physician trainees, you will be tasked to accomplish the certificate of death in one point in your lives. And this will come 3, 4, 5 years from now. So I know it might be overwhelming for you guys because accomplishing the certificate of death would already imply that you have already background knowledge on disease pathology. And we do know that pathology is a second year subject in the medical school. So it might be overwhelming for you, but allow me to guide you in understanding what needs to be written in the certificate of death, even though we do recognize it might not be applicable at your level as freshman medical students. So I beg your indulgence in guiding you in how to create or how to come up with a certificate of and how to accomplish your certificate of death. Now, the most important here, the most important thing to do, or the most important task given to doctors is what will we certify as the cause of death. And again, let me reiterate that ang assumption, marunong kayo mag-diagnose, a skill that you don't have yet as first-year medical students. Why is it important that we identify the cause of death? Because the cause of death will really be of help when we're coming up with mortality data. Being responsible for the clinical diagnosis of the cause of death, the doctor will play a pivotal role in the cause of death certification. The clinical diagnosis by a physician is the basis for certifying the death, and when entered into a certificate of death, it will finalize what we would sign out as the cause of death or the cause of demise of a particular individual. From an international perspective, all of us, all doctors, adhere to the ICD-11, or the International Classification of Diseases for Mortality and Morbidity Statistics. So both the World Health Organization and even in the PSA, we follow this, not the ICD-11. And again, whatever you put in the certificate of death, it must be congruent with what is being included in the ICD-11. Now, this is the latest data that I got when it comes to 2024 morbidity. Now, this is as of July 31, 2023. There are no other updated data coming from the PSA. But if you're going to look at the cause of death that is the leading killer among Filipinos, it's still your cardiovascular diseases, in particular your ischemic heart disease, followed by your malignant neoplasms, and closely by their stroke or your brain attack or your cerebrovascular accidents. However, let me be quick in saying that both your ischemic heart disease and your cerebrovascular accidents, they are all considered the more common exits of those patients who are considered diabetics. And diabetics would fall in the number 4 category as to the leading cause of death among Filipinos. So if you are diabetic, chances are you will die of either a brain attack, or that's what you call your stroke or your cerebrovascular accident, or you die from your acute myocardial infarction. And this is part of the spectrum of your ischemic heart disease. So to be the truth be told, these three are all interrelated. Ischemic heart disease, cerebrovascular accidents, and diabetes, they are all considered part and parcel of the metabolic syndrome, which could also technically be the precipitating factor for a person's death. So having said that, the consolidated mortality statistics will be the foundation of the country's health policies, plans, and programs. That is why if you look at the leading causes of mortality, most of these causes are non-communicable in origin. That is why it is important that when you come up with morbidity data, when you come up with program plans, you have a good knowledge of the leading causes of death in your geographical area of practice. Kasi if you come up with policies, they should address these public health burden. It informs the policymakers and planners on the leading causes of death, including patterns and trends, and therefore it is of utmost importance that the country's mortality data ought to be of good quality. Now, the road to good clinical quality data starts with the clinical diagnosis of the doctor as to the cause of death. Now, this is the first page of the certificate of death. Some of these information you get it from are basically known already, but the most pivotal here will be how do you accomplish the medical certificate. If you look at the medical certificate, sorry, I will go into the medical certificate in a short while, but notice that for the causes of death, it has three parts. You have your immediate, your antecedent, and your underlying causes, as well as other significant conditions that can precipitate or that could eventually contribute to the demise of an individual person. And we will go over this in a short while. We also have to look into what we call your verbal autopsy. The verbal autopsy is very common in the Philippines in the sense that uh, Dr. Alcanzade is a pathologist, but I'm not sure how many of our Filipinos really undergo autopsy. Unlike in the US, you have the coroners. If you any medical legal case, you automatically refer to the coroner who would conduct the autopsy routinely. In the Philippines, this is not so much, to my knowledge. I'm not a pathologist, but to my knowledge, it's not as practiced in the Philippines. But what we rely on when we come up with the cause of death, if there is lack of information uh, uh, as to what cause of death to write, we sometimes rely on what we call your verbal autopsy. Your verbal autopsy basically allows the person who would accomplish the death certificate to come up with a competent or a logical impression based on what will be mentioned or uh, what will be the most probable diagnosis. For the many deaths occurring in the country that are not attended by doctors, and this is so common, again, in the geographically isolated and disadvantaged areas, the best way of ascertaining the cause of death by the local authority is through verbal autopsy. This is conducted by interviewing family members who who are knowledgeable as to the probable cause of death. Perhaps they were witnesses as to the last when the patient was already exhibiting signs of death and dying. In the active phase of dying, they were able to see or they were able to personally witness the circumstances surrounding the demise of an individual. Then they could use these data to come up with your verbal autopsy. Now, this is the task of the local health officer, since he or she is the one who will be responsible for accomplishing the certificate of death for those people who died in the absence of medical practitioners or doctors. Uh, there's a message from Dr. Alcanzari. Sorry, I didn't see it earlier. Yes, Dr. Alcanzari?
Hello and good morning. Am I clear? Sige.
Yes, we can hear you.
So, okay. So one of the things that I experienced when I was deployed in Marinduque as a doctor to the barrio is that yun nga, the ability to perform autopsies is not only limited. You don't have the tools required to do yung yung histopathologic diagnosis. So most of the time, you rely on symptomatology. one of the things na nagmarka sa akin during my medical education, when I took an elective sa forensic pathology, ayaw na ayaw ni Dr. Raquel Fortun yung mga nagsusulat sa cause of death ng cardiac arrest or respiratory arrest. Okay, because back during the time I was a student so long ago, people actually put that dun sa death certificates and it skews yung ating statistics. So, yun, since we have yung verbal autopsy, we have yung pag-take ng history from the relatives, yun yung next best way talaga natin to ascertain kung ano yung probable cause of death ng patients, lalo na sa ating areas with poor access to health care and health services. And yung idea talaga kasi is, whenever we have yung mga sudden deaths na yan for patients, dapat talaga may autopsy. But yun nga, yung with our local context, with our local limitations, with what we have, yun talaga yung nagiging next best na approach natin. If there's one thing that I want our future doctors to learn here, mga first years, pag nandun na kayo, in case na nandun na kayo sa ganong klaseng situation, huwag niyo susulat dun sa death certificate yung cardiac arrest or respiratory arrest. Kasi it would be an insult to the education that you are being given. Yeah. Thank you. Yun lang.
Thank you, Dr. Edrina. He mentioned about Dr. Raquel Fortun. Just a bit of info. Dr. Fortun is a renowned forensic pathologist from the UP College of Medicine Department of Pathology. But she's also actually one of our 50 most outstanding UERM medicine alumni. So she is an alumna of the UERM College of Medicine, and Ma'am Raquel is renowned internationally when it comes to forensic pathology. And I also had the opportunity to be with her when I was still in training in UPPGH, and nakaka-intimidate si ma'am, pero I learned a lot from her as well. I'll actually talk about what Dr. Edri was mentioning in a short while when it comes to the writing of her certificate of death. So going back to the verbal autopsy, again, the World Health Organization has recommended verbal autopsy as a partial solution to the problem of lack of cause of death information in cases where there is no medical attendance, or it's like as mentioned by Dr. Alcanzari, in places where there is no capacity to perform an autopsy, whether you lack the personnel or you lack the facilities, basta hindi magawa, then we go with the verbal autopsy. Again, we interview next of kin or other caregivers, and this is where your communication skills will become in very handy when we're talking of verbal autopsy. Again, we use there is a standard questionnaire that is being employed, and it almost always probes on signs, symptoms, medical histories, or any other circumstances preceding the death of an individual. Verbal autopsy instruments are based on the following assumptions. Each cause of death has a distinct pattern of signs and symptoms, severity, and other characteristics. For example, when we're talking of acute myocardial infarction, if a patient suddenly complains of, let's say, severe retrosternal chest pain or chest heaviness with associated diaphoresis or fluctuations in the blood pressure, then sudden possible syncope, then chances are it's acute myocardial infarction. If a patient suddenly complains of sudden onset of the worst type of headache, and then there would be, let's say, sensorial changes, or there would be erratic blood vital signs, then that could be suggestive of a possible bleed in the cranial region. Secondary, let's say there could be subarachnoid hemorrhage, things like those. We usually identify common symptoms that are classically associated with a particular medical condition to allow us to come up with a more or less competent diagnosis. The signs and symptoms experienced by the disease can be recognized, remembered, or reported by family members and relatives. Therefore, it is possible to correctly diagnose deaths based on the reported information and to categorize them into groups of causes of demise that are useful for public health purposes. Again, the main objective of a verbal autopsy is to describe the causes or the manner of death at the community level or the population level where civil registration and death certification systems are sort of weak and where most people die, unfortunately, at home without having had contact with the health system. Now, again, there are two stages involved in the physician-coded verbal autopsy. As an interviewer, you visit the household where the death has occurred and you conduct your family interview using a pre-designed questionnaire and to record all responses in the standardized manner. And the pattern of responses is reviewed by a doctor. Sometimes this is the city health officer to determine the probable cause of death based on the signs and symptoms reported by the respondents. Now, technically, if the doctor is not allowed, if there is no licensed doctor who attended the death of a person, who can accomplish the certificate of death or who certifies the death of a person? Again, if you are the doctor, let's say the patient dies in the hospital, then it is the attending physician who will accomplish the certificate of death. However, let's say namatay yung pasyente sa bahay. And again, we see this among indigent members who die at home without being attended by a doctor. The one who would accomplish the death certificate would be the local health officer. This could be the city health officer or the municipal health officer. Now, in the event that there is no medical attendant at death and the local officer, for whatever reason, is not available, technically, the mayor or or any member of the Sangguniang Bayan or the municipal secretary may issue the certificate of death. However, this is only used for purposes of burial. Now, ito, ideally, no, under our laws, if we're talking of medical legal cases, then it should be the medical legal officer who should accomplish the certificate of death. Pero kung minsan, no, parang dami na kasi nangyari sa ating bayan, no? Many doctors question the credibility of the medical legal officers, especially from the PNP lab. Some of them are not really certified, board certified pathologists. Some of them don't even have formal training in clinical anatomical pathology, and yet they are the ones who sometimes sound like as if they are the real experts, no? But yan, technically, no, in paper, yan yung mga dapat. Why do we have the certificate of death? Why do we need to accomplish it? It's your prima facie evidence of death. We can use this for purposes of benefits, pensions, insurance, or tax exemption. Evidence of settlement of estate. This is something that you might also want to venture in, especially in third year when you go into medical legal or medical jurisprudence or legal medicine, yung mga estate planning, yung mga, especially kapag yung mga mayayaman na nag-aaway-away ang mga heirs sa property. So may mga ganyang mga reasons kung bakit natin kailangan ma-certify yung death. For those who want to have remarriage for purposes of surviving spouse, designation of a guardian or foster parent for a minor, and to determine health priorities for prevention of deaths that are of similar nature in the future. Now, again, the information is also significant for family members so that they know what caused the death and they are aware of conditions that may occur or could be prevented in other family members. So this is very relevant for us family physicians. When you know that there is a heredofamilial disease that might be seen in a particular generational issue, family lifeline, family medical lifeline, then you might also want to look into the cause of death of these individuals. So again, the death certificate would allow us to come up with existing information especially when we're dealing with infectious diseases or epidemics. We use this for the promotion of public safety for purposes of disease prevention and or eradication, for administrative purposes, among other things. No? Control infectious diseases, public safety, accident prevention, crime eradication, mortality surveillance, health and epidemiologic research, policy and program planning, and of course, the study of mortality differentials. So as I've said earlier on, this is the most crucial time this is the most crucial now for us to identify the immediate, the antecedent, and the underlying cause, as well as other significant conditions contributing to death. When I say immediate death, this is the most recent event that occurred that eventually directly led to the death of the person. Now, prior to the immediate cause, there could be intervening causes that link the immediate cause with the underlying cause. And these are what we call your antecedent causes. Now, the underlying cause of death is the disease or injury which initiated the chain of morbid events leading to the demise or to the circumstances of the accidents or violence which produce the fatal injury. Now, the underlying cause of death is the most important entry in the certificate of death because this is where your mortality statistics will be based on. Now, part 2 would look into other significant contributory coexisting or pre-existing conditions that could indirectly contributed to the death or the underlying cause of death. Notice that if you look into the death certificate, there's also what we call your interval between onset of death. Sometimes we want to establish now from the underlying to the antecedent cause, how long did that happen? From the antecedent to the immediate cause, how long did that happen? Sometimes it doesn't have to be specific. Hindi naman kailangan 5 minutes and 44 seconds. It doesn't have to be that specific. Sometimes we just put approximately 5 years, or if it's really not known, just put unknown. In general, we can put seconds, minutes, hours, days, weeks, months, or even years in this particular portion of the certificate of death. Now, a time range may also be used. For example, known hypertensive for the past 5 years, something like that. It's something that is acceptable. Now, the stated time interval between onset of cause and death will help to check the causes of death are written in correct sequence. The underlying cause leading to the antecedent cause, then leading to the immediate cause of death. So dapat, in terms of chronological events, the immediate cause should be the one that has the shortest interval, while your underlying cause should have the longest interval. If it occurs that after filling out the time interval, the antecedent or the immediate cause is older or has a longer time interval than the underlying cause, then there could be an error with the way the sequence of events were actually reported. Some medical directors also do this. Now, I remember in PGH, when we accomplish death certificate, sometimes we would be called by the medical director to address questionable causes of death when we certify cause of death in the certificate of death. So this is something that you might need to develop and learn over the years when you become licensed physicians already. So we also report yung infant death, no? For a while lang. For a while. I'm having technical difficulty. For a while, please. So dito, we also have to, sometimes when we're dealing with infant death, meron din parang ganito, no? Again, the important thing here is to also identify the cause of death of the infant. The thing with infant death, sometimes they are related to the maternal conditions. And that is why we also have to put these. For example, if you have a premature baby, I'm not sure if you've already studied lung physiology, but there is what we call your surfactant. Your surfactant is needed for normal breathing or respiration. It's something that our lungs will produce. However, for premature babies who are born, sometimes they have inability to produce sufficient levels of your surfactant. And so it can precipitate respiratory failure. This is what we call your hyaline membrane disease, no? When there is among premature babies that you would might encounter. So the hyaline membrane disease could be the one that could lead to the death of the baby. Hindi nakahinga ng mabuti outside of the outside of the uterus once the patient is out of the placenta. And so it can cause death. And why was there hyaline membrane disease? Maybe there is prematurity or there was preterm labor on the part of the baby. But the baby will not be born if there is no significant maternal condition that could also precipitate the prematurity. For example, if a mother happens to have pregnancy-induced hypertension, which we call your preeclampsia. So it's the preeclampsia, the maternal hypertension, secondary to the pregnancy, is the one that triggered the prematurity that led to the hyaline membrane disease. And usually, we see preeclamptic women if you are dealing with high-risk teenage pregnancies. So as you can see, when you come up with this infant death certificate, as I've said earlier on, it might not be appropriate for your level as first-year medical students because you have no background knowledge yet on pathophysiology. But this is why I have to guide you. I'm just giving you examples to make it a little bit clearer for you to really understand what we mean by these causes of death. This is what Dr. Alcanzari was mentioning earlier on. One of the pet peeves of Dr. Raquel Fortun, if you put ill-defined and non-specific causes of death, ill-defined causes of death under ICD-11 are considered vague categories or conditions that include only signs and symptoms or abnormal clinical and laboratory findings. Deaths assigned to ill-defined causes are insufficiently detailed to be of value for public health purposes. Hence, as a general rule, ill-defined conditions should never be entered as an underlying cause of death on the certificate of death unless nothing else is known about the disease. A common error is to report specific organ failure or the mode of dying as the underlying cause of death. These conditions are also considered ill-defined and should not be reported as the underlying cause of death since they do not usually occur without a precipitating cause. Therefore, if an organ failure is reported on the certificate of death, the underlying condition responsible for the failure ought to be reported as well. So these are some of the more common modes of dying that we don't normally accept or are considered vague. And so you need to identify a medical condition that triggered this. For example, when we're talking of kidney failure, what precipitated the kidney failure? Is this your diabetic nephropathy? Is this end-stage renal disease secondary to diabetic nephropathy? Is this secondary to hypertensive nephrosclerosis? Is this secondary to your polycystic kidneys? You have to give the etiology as to what triggered the kidney failure. Again, there are also what we call your garbage codes. These are again ill-defined or residual categories of major disease groups that do not provide meaningful information on the underlying disease or injury that triggered the death of an individual. So again, we try to avoid the use of these unless you could give a specific particular reason for the cause of death. Notice that the ICD, but this is ICD-10. We already have ICD-11. ICD-10, here you have I-469, which is cardiac arrest. This is what was being highlighted earlier on by Dr. Alcanzarin, that we try to avoid. We do not want to use these terminologies in the certificate of death because they are ill-defined and non-specific. We also sometimes see doctors who use mechanistic terminal events. These are pathophysiologic or biochemical derangements that are common final pathways that explain how the cause of death exerts its lethal effect. In general, mechanistic terminal events have an almost limitless differential diagnosis, ergo should never be reported in the certificate of death as one of the causes of mortality. Again, mechanistic terminal events are extremely non-specific and are of little epidemiologic value for mortality statistics that are derived from certificates of death. So ito yung sinasabi kanina, no? We don't want to see these in your death certificate. Respiratory arrest, cardiac arrest, cardiopulmonary arrest. Meron bang patay na humihinga? Meron bang patay na tumitibok ang puso? Di ba? Obvious naman, wala. So that's why we do not put these in our death certificate. These must be avoided at all times if you want to come up with a competent underlying cause of death. So again, just to reiterate, now some of them could be non-specific, but you can make it a little bit more accurate or more scientific if you give etiologies. For example, when you say sepsis, sepsis will indicate widespread systemic infection. But what is the focus or what are the foci of infection? Maybe you could put it. Is it urosepsis? Is it VAP on top of HAP on top of CAP? I'm sorry. VAP is ventilator-assisted pneumonia on top of hospital-acquired pneumonia on top of community-acquired pneumonia. VAP on top of HAP on top of CAP. So that led to the sepsis. Parang ganon. You need to give more credible or more specific etiology as to the cause of death. Now, also of importance are women of childbearing age. In the revised certificate of death, there is a new item that is labeled maternal condition. It pertains to women aged 15 to 49 years. They are considered of reproductive age, and whether or not they are pregnant, we have to identify this. The fact that the woman died during pregnancy or within 42 days of the termination of pregnancy should be clearly indicated in the under maternal condition, because this information, aside from its use in health research and statistics, is often used to identify those cases that need to be included in maternal death review. If you will recall from your lecture last time, the maternal mortality rate is of public health importance because it tells us of the quality of services available in a particular locality or in a particular geographical region. And so if you're seeing more and more women dying of pregnancy-related concerns or issues, then that is a red flag. It tells us that there could be poor maternal services. So you need to also, not just maternal, but healthcare services in general. That is why we give so much importance to this particular category in the certificate of death of women of childbearing age. We also identify maternal death, which refers to death of a woman while pregnant or within 40 days of termination of pregnancy, irrespective of the duration and the site of pregnancy from any cause, related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. The top causes of maternal death based on Philippine statistics would be your postpartum bleeding, complications of unsafe abortion because abortive practices in all forms will be considered illegal in the Philippines. Hypertensive disorders of pregnancy, which would include your preeclampsia and your eclampsia, postpartum infections, and even obstructive labor. Now, I also want to highlight here that last time I had a question, does this include your trans women? As much as we want to be inclusive of all women, the death certificate pertain only to biological women who have the capacity to be pregnant. So let me qualify that this part of the death certificate pertains to biological women with an XX chromosome, just so we're clear about it. And to my knowledge, we haven't really changed the death certificate when it comes to trans people, because this was a question raised previously. How do we certify the death of trans people? Now, other important points, if there is uncertainty in the entries of cause of death, it is always acceptable to use qualifying terms such as probable, presumed, and if the cause of death cannot be determined with reasonable medical probability, but seems to be due solely to natural causes, then the doctor can cite undetermined natural cause as entering the cause of death in the medical certificate. Now, other important things, now something when you are tasked to accomplish a certificate of death, so these are some of the data that you might need to include. You also use XMark when I'm filling up appropriate boxes and verify the accuracy of the identification, including the correct spelling of the name of the deceased. Especially for Filipinos. Filipinos are very fond of coming up with names that are so weird in terms of spelling. Yung mga, for example, bohoy, or girly, or vohong. Yung mga may H, kuminsan yung mga maling spelling na, again, these are legal documents. You have to ensure that everything is properly filled up. We do not make alterations or erasures. We do not use abbreviations or even medical symbols. And we prefer to use black ink rather than blue pens. Record only one etiology per line in the cause of death. Line A must always have an entry, but the others could be omitted. And always enter the underlying cause of death on the lowest used line in part 1. Now, we also have to look into mortality related to external injuries. The approach to writing causes of death involving external injury is to report the external cause or event as the underlying cause and identify the bodily trauma caused by the external event and report it as an antecedent cause, and lastly report the fatal derangement resulting from the bodily trauma as the immediate cause. The external event refers to an outside agent or force, usually physical or chemical in nature, that causes trauma, an injury or damage to bodily tissues or its function, and the trauma in turn may result in anatomic or functional fatal derangement that could lead to the patient's demise. For example, you have a patient who was rushed to the emergency room because of a vehicular accident. A fatal derangement there could be hypovolemic shock. Pwede na dinugo, extensive bleeding, whether internal bleeding or overt external bleeding. There could be massive blood loss that could lead to hypovolemic shock, and shock would eventually lead to multi-organ failure. For example, this is a vehicular accident. What triggered the hypovolemic trauma? For example, if there were multiple fractures basag-basag ang ribs, nabali ang femur, nabali ang humerus. Blunt force trauma, there is spontaneous rupture of your spleen. Or na-transect yung aorta mo. Now, these are all examples that you could put as to the antecedent cause. And of course, this is something that is secondary to a motor vehicular accident. Now, deaths from infectious diseases, the certifier has to also report the manifestation or the body site. If there is sepsis, where is the focus or foci of infection? If you already know the cause of the causative agent, for example, a patient suffers from pneumonia, but you know that pneumonia, and this is a person living with HIV or with full-blown AIDS or acquired immune deficiency virus. This could be your pneumocystis jirovecii pneumonia, or what we previously called your pneumocystis carinii pneumonia. So pneumocystis jirovecii is the causative agent, and you can put that in your cause of death. The source and route of infection can also be reported. Any underlying disease that may have suppressed the patient's immunity that made him or her susceptible to the infection that led to his or her demise. It is also important to indicate if there are reporting malignancies or malignant neoplasms, the specific site, the primary site, because you might encounter metastatic conditions wherein the mitotic cells have spread to various organs of the body. When we're talking of reported death, the cause of death, it's always the primary site that is reported. For example, if you have cervical cancer, the cervical cancer can spread to other types of organs. Then there could be multiple metastatic sites already. But what's important is you identify the primary site, especially those. Remember that your malignant cells have the capacity to spread either hematogenously or via the lymphatics. So make sure that you are able to properly identify these sites of metastasis. Now, if for whatever reason the primary site is unknown, then you cite primary site unknown. Then the certificate of death should always state the primary site, and often the primary site is reported as the underlying cause of death. Now, in a small proportion of individuals, there are people who can have multiple primary sites. And I have a friend who recently passed away in 2023. She had multiple primary sites. It started with breast cancer. She had her modified radical mastectomy, but again, it spread. And then after that, well, not really spread. It was either they were able to control it, but then after a few years, she had naman ovarian cancer, and then later on, nagkaroon pa siya ng thyroid. Talagang parang very sad, no? But her doctors signed her out as multiple primary sites. Thank you. Now, for fetal death, it refers to the demise prior to the complete expulsion of a product of conception, irrespective of period of pregnancy. The death is indicated by the fact that after such separation, the fetus does not breathe nor show any other evidence of life, such as the heartbeat or the pulsation of the umbilical cord. Remember, the umbilical cord has two arteries and one vein. So the pulsation of the arterial vessels in the umbilical cord should still be evident, or if there is no definitive movement of voluntary muscles on the part of the fetus, it could suggest fetal death. For academic purposes, when we say fetal death, we are referring to age 20 weeks and above. And normally this is calculated to the last menstrual period and to the date of delivery. This is something that you will learn when you go to obstetrics and gynecology. But I just wanted to show you that there is also an operational definition for fetal death. And that for fetal death, we also have to indicate this. Now, so for example, when you have abruptio placenta refers to the premature separation of the placenta from the uterus, so it will precipitate premature labor, preterm labor, no? And usually this could be secondary to external forces as well. Now, for example, if the pregnant woman happens to be a cocaine user, it can trigger, it can precipitate preterm labor that can eventually and consequently lead to abruptio placenta. So again, you don't have to always put terms for the A, B, C, D, no? Ang importante dito yung chronology. So again, when you go to when you go to obstetrics and gynecology, or perhaps to internal medicine and or pediatrics, you'll get to know more of these experiences, no, when we accomplish the certificate of death. I'll go to this in a short while. Now, the single most important or main disease condition in the fetus is centered in line A. And sometimes we accomplish line B if there is any. The main maternal condition should also be entered. And line E is reporting for other relevant circumstances which have bearing on the death of the fetus but cannot be identified as a disease or condition of either the mother or of the fetus. Now, there is also what we call your peri-procedural death, refers to demise that is known or suspected to have resulted in whole or in part from a diagnostic, therapeutic, anesthetic, or operative procedures. In medicine, we call this sometimes your iatrogenic or misadventure or accidents. No? If you look at it, it might sound as if it's something that is of negligence. However, we are quick to identify that many procedural deaths do not actually involve negligence, mistake, or culpability. For those of you who plan to practice in the US, a lot of attending doctors in the US pay a lot of premium for malpractice concerns. No? In the Philippines, this is not so much of an issue, but you might encounter certain patients now who might come up with absurd complaints against the doctor when in fact there's really no negligence on the part of the doctor. Your peri-procedural death can sometimes be expected, and it's not something that we always say, it's not always painted in the bad light. The structure and format used in writing cause of death statements for peri-procedural depends on whether the patient's demise is considered natural or accidental. So we also have an operational definition as to what comprises natural peri-procedural deaths versus accidental peri-procedural deaths. Now, if the physician has reason to believe or suspect that the cause of death was due to violence or crime, then the doctor is duty bound to report this to the PNP or to the NBI. So again, in an ideal situation, dapat ito nire-report sa NBI and NBI for possible autopsy. Ito yung mga examples, no? Stab wounds, gunshot wounds, suicide, strangulation, accident resulting to death, actual physical assault inflicting injuries upon a person resulting to death, and the other acts of violence upon a person resulting to death or sudden death of undetermined cause. So sometimes, akala mo natural death, yun pala merong poisoning na nangyayari. So these are some of the things that you might want to consider also. Now, one thing that we also have to identify is dead on arrival. Ano bang ibig sabihin? I have a question for the students. A patient is brought to the ER with multiple stab wounds, and the patient, when the patient came to the ER, he was responsive, he was able to talk, vital signs were stable, pero merong vital signs, patient was alert, coherent. However, 4 hours within the admission in the ER, the patient eventually died for whatever reason. Is this considered dead on arrival? Anyone? Ano bang definition natin ng dead on arrival? Can I hear from, I'll try to look for other doctors and other students. Can I hear from, hmm. Uh, can I hear from Miss Landicho?
Hello po, Doc.
Yes?
I think hindi po siya case of dead on arrival kasi Doc, meron po pong 4 hours na may signs of life yung patient upon
Okay.
arrival.
Sige, thank you for that. Let's try to see what our experts will tell us, no? When we say dead on arrival, emergency room deaths refer to patients' mortality occurring in the ER, including patients who were revived by initial resuscitative measures at the ER, but eventually died there, regardless of the time of stay in the ER. In such cases, this can be considered dead on arrival, especially if there is difficulty on the part of the attending doctor in the ER to come up with a definitive diagnosis. So the general unwritten rule, in theory or at least in practice, kapag ang pasyente dumating sa isang facility at namatay, and the patient if a patient comes to the emergency room and dies within less than 24 hours from the time of admission, then that is considered dead on arrival. And the attending doctor can refuse to accomplish the certificate of death for reasons that if the patient died in less than 24 hours, the attending doctor may not have the capacity to establish the definitive diagnosis. If this is the case, it is the prerogative of the emergency room officer if he or she will refer this to the city health office, who will then accomplish the certificate of death. So in theory, just so you know, if ever you become moonlighters in the future, kapag less than 24 hours, if a patient comes to your facility and the patient dies in less than 24 hours, you can refuse to write the death, to accomplish the death certificate, because this is considered dead on arrival. However, for humanitarian reasons, many attending doctors don't do this. They will still they will still accomplish the certificate of death, especially kapag medyo seasoned ER consultant na, emergency medicine consultant na, they can already come up with a definitive diagnosis by just eyeballing. That's also okay. However, again, the general rule for dead on arrival, yan yon. Basta less than 24 hours. Again, it says here, no, regardless of the time of stay in the emergency room. Other things that we have to consider for the certificate naman of live birth. So we're done with the certificate of death. We now go to the certificate of live birth. For a while lang. This denotes a pregnant state, both present and we have to identify the certificate of live birth, wherein we identify the gravidity, the parity of the woman. So important here that we have to identify let's say pregnant women who are, sorry, there's a typographical error here. A woman who delivers twins in the first pregnancy is still considered G1P1. However, in the subsequent numbers that are coded, we have to identify how many live births are there. No? So again, gravidity refers to the pregnant state both past and present, irrespective of the period of gestation, while parity connotes denotes a previous state of pregnancy beyond the period of viability. So other issues that you need to identify here for a while lang, for a while. So an important factor here is when we're dealing with illegitimate children. This is something that is also a bit sensitive because there could be issues on paternity. So if we're going to look at the certificate of live birth, aside from identifying the gravity and the parity, there is a portion at the back of the certificate wherein the father would have to, the father would have to recognize if this is an illegitimate child and whether or not the father acknowledges the child. From a legal medicine perspective, you also have to differentiate a legitimate from an illegitimate versus a legitimated child. So yung legitimate children, syempre ang dali naman ng operational definition yan. Alam na alam natin. Pero ano bang difference ng illegitimate sa legitimated children? Can I hear from the students? What's the difference between illegitimate and legitimated children?
Doc, from how I
Yes?
remember it, legitimate children are
I'm sorry,
conceived.
can you turn on your video camera? I can't seem to see you.
Okay,
Go
for
ahead.
example, so legitimate children are conceived within marriage, while illegitimate children are conceived outside of marriage, whether they are spouses or partners po. As long as there's no abiding law or abiding contract or marriage contract that states that the man and the woman is married, the child is illegitimate.
For a while lang, let me count. Dr. Gutita, I thought we scheduled I specifically told you to hold the exam from 8 to 8:30. Diba? That's why I requested the class to start at 9. Dr. Bitita, I scheduled the exam. I told you earlier on that the lecture will be from 9 onwards. Didn't I tell you that?
Po, ang sabi po is 9.
Diba? I told you that schedule the exam outside of the time of my synchronous lecture. That's why I told you last week of my schedule.
Outside of the schedule.
Our
Apa.
class is from 8 to 11, and I told you my lecture will be from 9 to 11, right?
Apa.
So the exam should have been somewhere from 8 to 9, outside of my synchronous lecture.
Pero yung tanong mo was what time is EPI, di ba 8 to 11?
Okay, so
And then you said you'll meet them at 9?
And I told you my lecture is a 2-hour lecture, right?
Okay. Sige po.
Okay, so in the interest, I will cut short the lecture. I will just, we will give priority. The assumption is the exam should have been, I told you during the meeting, I'll have the exam before my lecture. So my assumption was the exam was from 8 to 8:30. Remember, that was part of our meeting. I verbalized this during our departmental meeting. So anyway, so I will cut short the lecture to give way for the lecture, to give way to the exam. So let's have the exam na lang. Thank you.